thanks for sticking around. I'm sorry we weren't on earlier. So my background is I'm a clinician. I work in acute medicine and I was a GP. And as a result, I see the whole pathway. How many in here work primarily in the community? Stick your hand up. Thank you. And how many in the hospital? So lots in hospital. And how many at the interface? So this is the key area, really, and the focus of my talk, because I don't think we work in one area or another. We all work at the interface in one way, shape, or form, because patients come to us and they depart from us, and that interface is probably our key opportunity. I won't try and replicate the expertise that John Welsh has revealed, talking about the in-hospital deterioration. I couldn't come close. But I think, and I would venture, that the actual opportunity to reverse our outcomes from deterioration start far, far earlier than when they arrive in a hospital bed, but actually begin at their own homes and begin at the community and the journey into hospital and the interfaces. And if we think about the way patients travel across the care system, about the flow of both their movements as people, the flow of paperwork, data, electronics, treatments, we can start to envisage that whole care pathway and how, at the moment, non-standardized that is, and how, at some points, unreliable and subjective that is, and our opportunity at the moment for improving those processes, improving the reliability, the standardization, and the communication within to actually optimize outcomes. So, as John said, deterioration is the #1 cause of avoidable harm in healthcare. And when we take a deeper dive into the root cause analysis of why those deterioration events happen and death happens, communication tops the poll time and time again as to the most reasonable cause for why these episodes happen. And then when we look at other studies, and Hogan et al. Did an amazing PRISM-1 and PRISM-2 study into deteriorating patients to actually find out what the real causes of death were in these patients and whether they were truly avoidable. What we found was that we were getting better as a healthcare system in England, which is good to see. So a problem in care was only spotted in 9.4% of deaths investigated with exhaustive case net review in 2015, compared to 11.3% in 2010. Likewise, the avoidable deaths almost halved, from 5.2% down to 3%. So good signs and green shoots of improvement. But time and time again, it was revolving around the diagnostics, failure to recognize a sick patient, the severity, getting the diagnosis wrong, being very narrow-angled in our perspective as to what the cause of the deterioration was without being wide-angled and thinking about all possibilities, putting people down pathways specific to one condition rather than being more wide-angled and accepting wrong and keeping our options open. And then the management of deterioration itself, the spotting, the recognition, the response, as John mentioned, monitoring and the assessment therein. So lots of opportunities to improve. And what we need to come to as a conclusion before we go any further really is to think about what it is that really kills patients, because it isn't a specific condition like sepsis that does it. And I say this as a sepsis specialist. It's the deterioration within the sepsis that causes the death. The deterioration that leads to the organ failure that then leads to the death. And that precipitant for that deterioration could be anything, from infection to any other cause. So the key element is recognizing when someone falls off their perch and the deterioration begins to happen. What deterioration in function and what deterioration in physiology occurs that informs clinical decision-making and judgment to escalate a patient and get worried. And how that severity maps to a transmissible communicable score, a score we call the National Early Warning Score. And to that end, it was very heartening to see the implementation guidance for sepsis pull in along those lines to actually bring together deterioration and sepsis under one banner and have one way of defining sick people across the entire care pathway. And what this did was it forced us to do and actually start to measure and assess how fast and how timely we were in our ability to respond to someone who physically demonstrates evidence of deterioration. And what cause of that deterioration, it doesn't matter. The point is, it's been noted, someone's sick, they need urgent review. The pathway and the system has to respond. Because if we just think about sepsis on its own, we will miss the 90% of everything else that's bad that's going on and fall down those traps of deterioration that have plagued us for the past 20 or 30 years. It's about being wide-angled and considering that sepsis is an important part of deterioration, but it's not the only thing that can go wrong with you. And our opportunity right now is to think about how we can implement this early warning score into our way of being, both as hospitalists, as generalists, as community, as interface physicians and clinicians, and systems leaders, to try and ensure we actually are on the same page. It gives us an opportunity to think about this concept of a combined all-cause deterioration pathway, where we think about levels of risk and then a reliable response based on that risk, no matter what environment you're in. This is what we did across Wessex, 5 million population, got all the heads of deterioration and sepsis at each acute organisation and each community setting together in a room, met 3 times, and then we determined some escalation triggers and levels across the whole population in all settings. And it was a lot easier than it sounds, because we were reaching out for something that would work for everyone in general practice, everyone within a community care home, an ambulance, in every single department in hospitals, to make sure we're all on the same page. And we have to accept that it's not going to be a magic drug that is the next best thing in the NHS. It's not going to be an advance that is some technological breakthrough, but it's more going to be the way we work together as a pathway and a system. The Tower of Babel that we currently exist within has to crumble. The language we use has to be synergized so that there aren't 25 different ways of describing how sick someone is, based on your history and what you culturally accept as sick. And we have to be more reliable at using one of the greatest tools at our disposal, namely the vital signs, because they predict death 80 to 90% of the time. It's what we do when we see a patient. We do the vital signs. But how many of us actually understand what those vital signs really mean? Why do you really check a blood pressure, a breathing rate, a pulse rate? And this is the message NCPOD tried to get through to us with its reports into patients with sepsis and all-cause deterioration that have died. And there have been 20 national reports that have said the same thing over the past 20 years. We might be a little bit better, but we haven't cracked it yet. And our opportunity, perhaps, is that common language. We know communication is the number one cause of, or root cause of harm. If we can standardise our communication, if we can standardise the pathway of care and the language within, and we can improve the reliability of taking observations, as this practice, this is an out-of-hours service in Liverpool, and they managed to improve their compliance with taking full physiology in a new score from 5% to 90% inside a year, after a patient with sepsis who died in the car park having not had physiology taken. Now, the key is not waiting for that case to happen before we have an effect on our service, but to do something more proactive. Because by knowing how sick a patient is, we can better prioritise and plan what happens to patients as they traverse the system, be prepared and place them in the right and most safe and appropriate environment. In my patch, we have 34 ambulances looking after 5 million patients in 10 hospitals, and 15 are outside one hospital at any one point depositing patients, leaving 20 to look after all the GP referrals and self-referrers that become sick. If there is no language of describing physiological risk, they are in a really difficult position at judging who needs to go to what case most urgently and over what time course. So it's the responsibility of everyone in the pathway to help probably the most highly pressured area of healthcare, which is the ambulance call handler, dispatching ambulances, to my mind. That's the resource we don't have enough of. And our opportunity with the patient safety alert, now that news is mandated across all ambulance and acute trusts, is whether we can branch out and bring this into the community and think about the concept of baseline more to help inform our decision-making about when someone truly deteriorates, because there's no use in saying someone has a news of 5 without realising what they were like yesterday or what they are like normally, as we know from our chronic respiratory patients. Our opportunity 10 years on is whether we can implement news across the care pathway. And the push and pull therein, the strategy of actually bringing it into the everyday communication, with hospitals and departments in hospitals asking for this score at all referral points, as they are in all ambulance services now, from all comers, be it from a hospital, GP, care home, you name it. And the push and the pull of this will guide the success. And when you see it in action, when you start seeing nursing home news charts filled out, and that communication happening early, with all the escalation decisions made and decisions made and carers contacted, it's a thing of beauty, because we can be more efficient and effective. We can also plan our services in the hospital better, as we have done with our ambulatory clinic, and our determinations and lines in the sand of where we manage patients based on their physiological risk. If you're a low-risk patient, you can be ambulatory. If you're moderate, you probably need a trolley, or you need a majors cubicle. And if you're really high risk, you need to be in resus. And just those simple placement decisions saves lives, because it's not very much fun when you're trying to intubate and perform CPR in a patient in an ambulatory clinic or a corridor. But it's not validated as what they've said. And this has been the big barrier. And this is a bit hot off the press. We're just impressed with this article that is essentially going to validate the use of news across the care pathway. So now you're glad you stayed. 1,503 patients referred to HHFT medicine, that's my trust. And we looked at those who died within 5 days of admission. And we found that actually, it's surprise, surprise, if you have bad physiology in general practice or your community care home, you're more likely to die than if you don't. So this was the whole bone of contention of why we've had resistance in some sectors to taking on news across the whole care pathway. But actually, it's not true. So the average news of survivors in general practice is 2.8 versus 4.78 when they come into emergency admission in those who die. In ED, it's 2.6 versus 6.73 in those who die. In resus, it's 5 and 11. And then we looked at 21,000 patients who were referred to the medical services from the community, ambulance, and everything else. And we found that the simple act of recording a news score electronically and on the phone meant that the mortality rate in those where a news was captured was 9.8%. And if you didn't record it, it's 16%. It's staggering, isn't it? If there was a drug that could do this, we'd be buying it like a shot. Now, I think this is only one part of the puzzle in terms of validating news across the care pathway, but it validates the use of a common communication tool and a common language and a common way of describing sickness so that all across the pathway are aware. And what it shows also is that when people know this data, they suddenly become a hell of a lot more reliable at capturing the news. So my junior doctors now do it about 90% of the time at all referral points, having come from a position of 0% this time last year. And indeed, it was only really December time that we started releasing this data to say, look, this is actually the difference in mortality when you take this score compared to when you don't. And we need to do the same in every single hospital, in every single healthcare environment, because this is the truth, and this will save lives. And what we've done in terms of the breakdown of about 20,000 patients worth is actually looked at individual news scores from all calls referrals to see what the OROP, so the error under receiver opt-in curve, looks like. And we found at every single level where it goes up, mortality increases. So again, it's the validation for it. We hope to get this published by March. And this is, I think, going to change the situation. And when you start seeing in real life patient examples, 56-year-old lady seen by 2 different GPs, one in the morning, one in the evening sessions. She was safety-netted really well in the morning. She had a right lower lobe pneumonia, given amoxicillin to treat that. She had risk factors. She was on immunosuppression for rheumatoid arthritis. Her news was 2, seen by the first doctor, well documented, and told to come back if she didn't feel any better. She felt worse. She returned to the afternoon surgery to see a different GP. Continuity's gone in all environments. But that GP looked at the earlier note, saw the news was 2, and realised that this was a sicker patient that they were seeing in the afternoon session, a news of 6. They tried to get hold of the medical team to refer the patient up. That was our tradition. We asked for the referral. No one was available. We were in extended cardiac arrest with a 40-year-old man that took an hour and a half to bring him back. So no one could get to the phone. That GP would, in the old days, would have had the patient in the waiting room, waiting, unfortunately, until a medical person accepted the call. They saw the sense and logic and thought, this is someone who's probably had sepsis. Let's get this patient in. I'm worried enough to just go straight for an ambulance and get the patient to the emergency department. That empowerment and that ability to go beyond necessarily the pathway with the evidence of physiology help this patient get blue lighted to the emergency department. Antibiotics in within 45 minutes. The patient was home within 2 days and not dead. And this is the story of what this can do in action. And Celia Ringham-Clark heard about this story, the medical director for clinical effectiveness, and sent this amazing letter saying, well done for essentially managing this patient correctly. It came a day after this case, so it was incredible feedback, and that's what we really need to be good at doing. We need to be not blaming and pointing fingers when things go wrong, but actually rewarding and praising when things go right. And this letter arrived in the surgery. They put it up in a framed letter front at the front of their reception on the same day the CQC came to visit. This was in Andover, which is quite a small town. Well, it's about 40,000 population. By the following week, every single GP surgery in Andover was using news. And, these are the stories that change hearts and minds. And part of this is actually thinking about what we do with deteriorating patients in the time before. Because if you wait for medical symptoms to develop, it's too late. By the time a cognitively impaired person knows they're breathless, or someone with learning disabilities, or someone with mental health presents, they're not going to say, I've got a cough, I've got pleurisy, I've got breathlessness. They're going to say, I'm off my food, or a carer is going to note they're not quite functioning and firing on all cylinders. And those are the elements of an all-cause pathway of deterioration we need to consider before that dreaded emergency admission happens, before it's too late. And those soft signs, which comprise of function, behaviour and concern alterations, have a taxonomy amongst, all of their own that I'm very happy to share. There are about 50 separate symptoms that people really complain of before they become sick. This is not, medicalised nursing symptoms. This is about what people really feel. And as a result, something are far more sensitive. And we need to validate that over time, and that's coming. This is a care home chart that encapsulates it all, and again, very happy to share it. And again, builds on that use of, I suppose, what deterioration is in care and nursing home environments. This is the vision for electronics and an interoperable digital system that will enable the transmission of news across the care pathway real term, across my patch certainly, but it's a model that could be done anywhere in the country. And this is the driver diagram for what we're aiming for at NHS improvements over the next 5 years in approaching deterioration and the things we hope to do within it. Thank you very much.